The next case is going to be presented by Dr. Kirti Puramaya.
Okay, just once again here. I thought I'd just give you a small little how I plan unstable patients. Lots of people have hemodynamically unstable patients, and how do we plan these angioplasties and PCIs in the setting of a ST elevation myocardial infarction, or in the setting of a high-risk PCI, which has low LV function, and how do we do this? I think, oops, it doesn't want to move. One moment. One moment. I don't know what's wrong, but we had a little issue with you. Yeah. So to start, let me start with an example, and this is a 78-year-old gentleman who presented to us with an anterior ST elevation myocardial infarction in December of last year. He came in with 3 hours of chest pain in the early hours of morning, and when he arrived at the hospital, he was cold, clammy, sweaty, with a blood pressure of 80, heart rate of between 90 to 100, O2 saturations of around 90%, and this was on 6 liters of O2 in the CCU. His creatinine was 1.7, hemoglobin of 11.5, his sodium was 135, and a potassium of 4.6. He had a background history of Parkinson's, for which he was taking Syndopa, and this was his coronary anatomy, and you can see he's got a non-dominant right coronary artery, which has got a tight narrowing, which gives rise to collaterals to the entire LAD system, which is occluded now, calcified, and heavily calcified, actually. A very prominent proximal circumflex lesion and a very nasty circumflex lesion, which is going into an OM branch, which is heavily calcified as well. But both these arteries had TIMI3 flow, the LAD was occluded. The question was, how do we manage this patient, and how do we make him good for a PCI? We electively ventilated this patient. We put him on a dobutamine infusion of 7.5 mics along with noradrenaline to maintain a systolic blood pressure of around 110, and that's what our aim is, basically. Once we do that, what we did was we systematically did an angioplasty on this patient and put in stents into this LAD. Somehow the animation over there was not appropriate. 3 months later, we got this patient back with a nuclear imaging showed a moderate size inferior infarct anteriorly and a reversibility in the infrapostural wall. His EF was now 30%, and his left ventricular end-diastolic pressure was 18. So we went ahead, and you can see that the LAD has got a good long-term result from the stents, and this is around 3 to 4 months. And we went and approached this circumflex, and this circumflex was done microcatheter, a rota wire, a 1.5 burr, and once we had that burr going in, one single stent, two stents expanding right from the proximal part of the circumflex right beyond this branch here. And I was guided to make sure that we got optimal sizing, and this is the result. This patient's doing well now. So do we use intra-aortic balloon pumps? The randomized trials, and if you heard the lecture in the previous hall over there, the randomized trials show that the 30-day mortality with the IBP SHOCK 2 trial shows that there's no advantage of intra-aortic balloon pumps over conservative management. The left ventricular ejection fractions in people who intra-aortic balloon pumps were used was not any better than where it was not used. And if you look at the previous data, then we know that intra-aortic balloon pump comes at a price of a higher stroke rate of 2% and increased bleeding of around 6% in various trials. This was not shown in the IBP SHOCK 2 trial because I think the SHOCK 2 trial was there's a lot of noise in the trial because of crossover of LVADs, the use of LVADs in the control system, and the huge amount of crossovers wherever they were. So the bleeding got balanced because of LVADs, and the benefits of the LVAD in the control group was diluted by the bleeding complications. So nothing really made sense in that trial. And this was the 30-day mortality of the primary endpoint of the trial, based on which a lot of people questioned the role of intra-aortic balloon pump. But Brian very eloquently showed a case and made a case for it, that there is still a role. The question is we need to identify where. And these are the randomized controlled trials on the cardiogenic shock. And what I take home from this is one thing which has changed in my practice is that early revascularization, we all know, but this is important. And if anybody's looked at the SOAP2 study, which is the cardiogenic shock subgroup, we look at 30-day outcomes in around 60 patients. And we see that when you start using norepinephrine, is much better than dopamine in these patients. And this is something which is substantial. So we don't use dopamine in these patients anymore because it increases arrhythmias, it increases myocardial oxygen demands, and it increases complication rates for us, and no benefit. So our drugs of choice in this group of patients is dobutamine and noradrenaline as a combination. We have simplified our approach in this group of patients, and so we prepare our patients doing a left ventricular end-diastolic pressure, which is very simple. If a ventricular intradiastolic pressure is around 20 to 25, we just use contrast very cautiously. And in this group of patients, our interventions are primarily IVUS guided. If it's 25 to 30, we give intravenous Lasix as required, but this patient would then have dobutamine and noradrenaline infusion to maintain a systolic pressure of 120 at the end. Beware that when you start noradrenaline on these patients, you've got to monitor them and you've got to look at their toes every day to see if you start seeing any cold toes with bluish duskiness, then you've got to stop and taper noradrenaline quickly, otherwise you start getting ischemic and end arterial damage to the toes. If the end-diastolic pressure is more than 30, we have a very low threshold to ventilate these patients, intubate them and ventilate these patients. And of course, you have to do everything, like you have to give diuretics and you give them dobutamine and noradrenaline. And this is, we do not use intra-aortic balloon pumps in our patients, and in our high-risk PCIs, which are non-ST elevation myocardial infarction, we've not used, now we've done more than 40 of these, on ventilator, and we've not used intra-aortic balloon pumps on any of this. And this is a classic example of one of our cases. Typically, an elderly lady with 85, acute coronary syndrome, creatinine of 1.8, left ventricular ejection fraction on echo is 30%, and LV end-diastolic pressure is 36. If you put these patients and start doing PCI and angiograms on this patient, because of this, very soon you'll see that this patient goes into florid pulmonary edema with cardiac arrhythmias. What we do is we give them dobutamine and noradrenaline, electively ventilate, Foley's catheter in all these patients, and then we plan a rota to the right systematically. And once we've done that, you realize that the end-diastolic pressure comes down. We go ahead in the same sitting, go and do the left main with a rotational atherectomy, complete it with a great result. And these patients do well. And we're looking at almost like 40+ patients now with the same methodology. What are the parallel things that I look for? And the parallel things that I look for are renal functions. We look at cystatin C results in most of our patients. In all our patients get a cystatin C level. We do GFRs and creatinine clearances in all these patients at some stage. Contrast nephropathy is a feature in most of these patients, so typically the creatinine levels will rise on day 4 and 5. What is important is that as long as the creatinine levels are still rising, don't be in a rush to extubate these patients. We keep those patients on a ventilator till we see that the creatinines have settled down and then extubate these patients, because the last thing you want is reintubation of these patients. Naturally, a lot of these, there's a compounding problem in this elderly group of patients because a lot of them have some kind of sepsis along with them, and procalcitonin levels, if they are high, we have a low threshold to start these patients on intravenous antibiotics. Because if you look at some of the data, and the recent data in JAMA and some of the other journals, it shows that when procalcitonin levels are high in cardiogenic shock, antibiotics actually improve outcome in this group of patients. NT-proBNP we use frequently in our lab, and now in some patients we use BNP because of the better value of repeated use after in 7 days. And this guides our diuretic therapy over the next few days. Anemia correction is extremely important, and we have a low threshold to give these patients packed cells to make sure that we have an adequate oxygen carrying capacity in these patients. Acidemia and lactate levels are important to monitor prognostically. People who are in persistent acidemia with high lactate and increasing lactate levels are going to be the ones who are not going to make it. Largely, there is a large unmet need for safe supportive devices in my practice, and particularly in our country. A team approach with an anesthesiologist and an intensivist helps, and that is a norm in my practice. And given the limitations, there will be a case that we just cannot do, and we have to simply accept it because we're not going to pull those patients through. So if I put these patients on a ventilator and I'm not able to get a systemic blood pressure, it is okay to say that if I do this, the mortality is going to be high, and I do not attempt it. And so humility and withdrawing and making sure that we don't do damage is important. Thank you again.